Hello, it's my utmost pleasure to be with you today for the second time on this second international conference hosted by the Pain Bangladesh Society. I'm Dr. DrSherryFanousClinic, and my talk today will be about neuromodulation in shoulder joint. That's our topic today, shoulder joint neuromodulation. And this is my conflict of interest. So let's have some introduction. The prevalence of pain in shoulder joint ranges from 18 to 26%, usually in females more than males. The most common parts to have a pathology in the shoulder joint are two big joints within the shoulder, which is the acromioclavicular, as this is the beauty bone, the clavicle. As we go further, we found here a joint, and this is the acromioclavicular or AC joint. Another big joint, which is the glenohumeral joint between the scapula and the humerus, and this is another joint which usually suffers from osteoarthritis. Our rotator cuff muscles, three of which usually tends to have pathology, like the supraspinatus, infraspinatus, and subscapularis. Those muscles, those are the rotator cuff muscles which cause the ball and socket, the humerus, and the scapula to keep rotating. Those muscles usually tend to have problems in them. And the incidence of problems usually starts to increase by aging. Nowadays, I see those kind of pathologies in younger age due to the fast pace of life. So that's the anterior part of the shoulder joint. As we can see here, that's the clavicle. And that's the supraspinatus. It goes over the head of the humerus to be inserted here. This is the course of our supraspinatus. It goes like this to be inserted in the humerus to cause abduction. Another muscle we can see on the anterior view of the shoulder is the subscapularis. That's the subscapularis. It goes from here to the side, lateral side, to cause internal rotation of the shoulder joint. Another muscle or tendon that can cause pathology or pain within the shoulder joint is the bicipital tendon. That's the biceps, and that's the tendon. It goes in the bicipital groove. Usually the patient comes with a specific type of pain. He or she says, I have a pain right here, and he can define it with one finger. Usually this is the bicipital tendon. Let's have a look on the posterior part of the shoulder. That's our supraspinatus. And this is the most famous subacromial subdeltoid bursa. And underneath the ridge of the scapula, we can find our infraspinatus and the teres minor. Those three with the subscapularis from the anterior form the rotator cuff muscles. From the lateral view, if you are going to look on the lateral side, that's the humerus. And here it's a beautiful view, as we can see all the rotator cuff muscles from below, from the posterior part, posterior inferior part. We can see the teres minor. Above it is the infraspinatus. Above it is the supraspinatus, and anteriorly lies the subscapularis, and we can see the long head of biceps here. This is a superior view, as we can see that's the clavicle, and that's the acromioclavicular joint. If you are having a look on the acromioclavicular joint with the ultrasound, sometimes you can see the supraspinatus fibers passing beneath the acromioclavicular joint. And here is the supraspinatus tendon and the infraspinatus tendon. So let's have an important talk. What's the shoulder joint innervation? Let's summarize it to say for the inferior part of the shoulder joint, whether anteriorly or posteriorly, the inferior part, we have superior, inferior, anterior, and posterior. Okay, for the inferior part, anterior and posterior, the axillary nerve is the main supply. For the superior part, in the posterior side, the suprascapular, and in the anterior, we have nerves of the subscapularis and the lateral pectoral nerve. That's a summary for the innervation of the shoulder joint. This is the suprascapular nerve, and that's the lateral pectoral nerves, and this is the axillary nerves. So what are our targets for neuromodulation? Most of the studies target the suprascapular. It's our beloved, the suprascapular, which usually they targeted in the suprascapular notch. A recent study have shown that they can target it in the sphenoglenoid notch, away from the motor branches which supplies the joint. Anyway, the suprascapular is the most targeted nerve in the shoulder joint, and the axillary, it passes here, is another frequently targeted nerve. Also, we have some studies reported targeting the lateral pectoral and the subscapular nerves. Some studies also target the branches supplying the glenohumeral joint over the capsule of the joint. Clinically, how would our patient present? You have different presentation for the shoulder pain. If the pain is originating from the glenohumeral joint, usually the patient will complain from pain anteriorly and posteriorly, and it may be referred to the ipsilateral arm. If the pain is coming from the acromioclavicular joint, which is the joint between the clavicle, the beauty bone, and the acromion, usually it's localized on the acromioclavicular joint. If the patient is suffering from bicipital tendinitis, usually it's on the biceps tendon, and he can define it with one finger. And that's my tip and trick. If the patient can define the pain with one finger, usually it's the AC joint, according to the location, or the bicipital tendon. For the impingement, we have subscapularis impingement. When the subscapularis doesn't go totally underneath the coracoid process, or supraspinatus impingement, when the supraspinatus doesn't go totally underneath the acromion. Usually for the supraspinatus subacromion impingement, the pain is over the superior lateral area, anterolateral area. If it's the subscapularis, the pain would be radiating to the lower part of the arm. It's very common now to have patients presenting with pain post-surgical. A couple of months ago, I had a patient flying to me from Germany. He had 2 surgeries in the shoulder, and it ended by motor affection of the shoulder and the arm. So it's very common now to have patients with shoulder pain post-surgically. It accounts for about 22%. Also, we have to keep in mind referral pain. Sometimes shoulder pain is just a referral from cervical facets or from the muscles here, because we have here the trapezius, and it can cover the upper part of the shoulder joint, so it can be a referral pain. So you have to examine your patient very well. Diaphragmatic irritation can cause also shoulder pain, or apical lung malignancy can be presented as shoulder pain. What are our modalities for neuromodulation? The main two modalities now, we have the fluoroscopy and the ultrasound. Fluoroscopy is limited to the suprascapular nerve in the suprascapular notch because it lacks an important feature, which is the color Doppler, which is present in the ultrasound, making the ultrasound a better modality in targeting several parts of the shoulder joint, so we can avoid the injury of the posterior circumflex while targeting the axillary nerve. We can avoid the injury of artery while targeting the suprascapular. Also, if we are targeting the nerve roots in the interscalene approach, as you know, because the axillary and the suprascapular are the fifth and sixth cervical nerve roots. So if you are targeting the interscalene, the nerve roots by the interscalene approach, you have this area is full of vessels, the jugular, the vertebral artery, and lots of arteries passing in there. You can do it by fluoroscopy. So it's a better modality to use ultrasound guidance. What's the role of prognostic block prior to neuromodulation procedures for the shoulder joint? Usually it's done before the ablative radiofrequency. If I'm going to ablate the nerve, I'm going to ablate the motor and sensory branches of this nerve, I can go for prognostic block to know what's exactly I'm ablating. And usually this happens in patients with malignancy or motor affection. For the pulsed radiofrequency or neuromodulatory approach, there is an overlapping innervation for the shoulder joint. So the prognostic block would be rather predictive than prognostic. Because it have significant false negative and false positive rates. So for me personally, I don't do prognostic blocks for the pulsed radiofrequency for the shoulder joint. Types of neuromodulation, we have the ablative form, as we have stated. Temperature ranges from 70 to 80%, and it results in the destruction of the nerves. As we said, mostly we use this in malignancy-related cases. For the PRF, temperature is usually 42 degrees, and the duration ranges from 240 seconds till 8 minutes. Study shows that the longer exposure for neuromodulation, the better effect that you are going to have. Series for pulsed radiofrequency are due to nociceptive transmission, modulated, altered gene expression. Another form which is now started to be used in papers, which is the cervical spinal cord stimulation. For optimal usage in shoulder joint, it has to be above C5. It stimulates the dorsal column, which causes neuromodulation for the shoulder joint. However, the problem with the spinal cord stimulation in the cervical area is the mobility of the cervical spine, making it vulnerable to paresthesia coverage. I believe we need more research papers for this category of patients with shoulder pain and non-responsive to conventional types of neuromodulation. We need more papers to see if the cervical spinal cord stimulation would be a better choice. Another form is a peripheral nerve stimulation. I invite you to read this amazing paper from Mazzola and Spinner. which they summarize all the papers which have been talking about or demonstrating the peripheral nerve stimulation in cases of shoulder joint. Usually, the targeted areas are the suprascapular and the axillary nerve, which makes us come to one point. So what if we have some nerves affected, like the lateral pectoral and subscapularis? Would there be a choice? Would we see a paper targeting those nerves also? I invite you to read this paper. It's really good one. So that's one of my patients. He was having an impingement, supraspinatus impingement. As we can see here, that's the acromion, and that the supraspinatus muscle, and above it is the deltoid. And you can see the black line here, that's the subacromion subdeltoid bursitis. And you would see my needle coming from targeting the bursitis. And I did pulse radio frequency for these patients, and he improved very well. That's my needle. It's coming from medial to lateral, targeting the subacromion subdeltoid bursa. That's my needle, as you can see it. And that's the bursa. It was targeting the bursa. That's another case. This patient, he was a worker, he was a handyman, and he pushed a hard object, and he started feeling a loss of function in his shoulder. EMG demonstrated affection of brachial plexus at level of C5, 6, which affected the shoulder joint. So I managed to perform interscalene approach for C5 and 6 nerve roots. As you can see here, that the C5 nerve root, C6, and my needle is coming in there, and that's the 2 scalenes. And I did pulse radio frequency for this patient. For targeting the suprascapular nerve, usually we place the transducer above the scapular ridge, and we tilt it, that's the scapular ridge, and we tilt it upward in order to see the supraspinatus and trapezius, and that's the subscapular, suprascapular notch, and the transverse ligament. Above it is the artery, and the underneath in the notch is the nerve. That's the trapezius, the supraspinatus, and the notch, and the suprascapular nerve is here, is within the notch, and the artery is above the transverse ligament. Let me share with you a procedure with one of my patients. That's one of my patients. This procedure is filmed on my YouTube channel. As you can see here, I'm targeting the suprascapular nerve. That the supraspinatus, above it is the trapezius, and that is suprascapular nerve in the notch, and above it is the transverse ligament. You can see that the patient's position is the targeted shoulder is on the upper side. He is lateral, he's lying lateral. And here I'm targeting the nerve. You can see my needle is coming in here. That's my needle. It's on the transverse ligament. That's my needle. That's the transverse ligament. And that's the suprascapular nerve. Now I'm in the targeted area. I would start motor stimulation. I start first sensory stimulation and then motor stimulation. You would see the supraspinatus and infraspinatus moving now. Supraspinatus and infraspinatus muscles were both moving because I'm in the right targeted area. So for targeting the axillary nerve, my probe would be in the posterior lateral part in the area between the head and neck of the humerus and the shaft. I'll be looking for the circumflex artery with the Doppler, and just lateral to it, just adjacent to it, there will be the axillary nerve. I'll go from caudally to cranially, and then start stimulation, sensory, then motor stimulation. This is one of my patients, which I was scanning at the clinic. As you can see, that's the neck of humerus, and the neck of humerus. My target will be here between the neck and the shaft, and I'll start applying Doppler to confirm the presence of the circumflex artery. Here in the operating procedure, that's when I'm targeting the axillary nerve. As you can see here, that's head and neck and the shaft of the humerus. I'm applying Doppler. I'm looking for the circumflex artery because my target, as you can see, that's my probe in the posterior lateral part of the humerus. Actually, this is the best ergonomics in which you are you are facing your patient and your machine. That's the best ergonomic you can do. And I'm looking for the artery, and just lateral to it would be the nerve. Here is another patient. That patient had several problems. Here I'm targeting the glenohumeral joint, the capsule of the glenohumeral joint. I applied pulsed radiofrequency for 8 minutes for this patient because she had effusion and osteoarthritis at the glenohumeral joint. That patient, several types of surgery and all failed. As you can see, that the glenohumeral joint, the infraspinatus, and my needle is coming. As you would see, my needle is coming in here. That's my needle. That's my needle. My needle is coming on here, targeting the capsule of the glenohumeral joint. Here are my fellows. They are watching the procedure, and I'm teaching them how to approach and explaining the procedure for them. Thank you very much for your attention. Those are my contacts. I'd be glad to receive any comments or questions from you, and hope you enjoy your time in the conference. Thanks for the organizing committee for inviting me. It's my greatest pleasure. Hope to meet in the 3rd International Conference. While be presenting there. See you soon. Thank you.